Okay, so let's start. So this class is about diagnosis of pregnancy and some of the common complaints during pregnancy. So important topic, okay? Every topic is important, and we cannot take less important topics because we're having only two classes per week. So the must know topics will be taken, and if I feel some more discussion has to be done, okay, I will tell you what are those topics, and I'll probably send those on the group. But more important topic, I like to take these online classes. This is important one. So how pregnancy is diagnosed and what are the common complaints of that pregnant lady during the overall duration of pregnancy, during first trimester, during second and the third. Let's talk about it. Now see here, pregnancy can be diagnosed by different signs which are called presumptive sign, probable sign, and the positive sign. You see here, presumptive sign, probable sign, and positive or definitive sign, you can say. So we need all of these, okay, or we get all of these when we take history or doing physical examination of that pregnant lady. So let's talk one after other. What are the presumptive signs? It is unrelated, or these are unrelated to uterus or fetus, and these are amenorrhea. We all know what is amenorrhea. This is cessation of menstruation. Okay, this is example of secondary amenorrhea. Now, primary amenorrhea means the lady never started any period. Okay, there was no menarche at all. This is primary. But pregnancy is a perfect example of secondary amenorrhea. Okay, breast tenderness in the early part of the period of pregnancy, that pregnant lady feels tenderness or heaviness of the breast. Okay, this is a subjective feeling. Nausea and vomiting. This is called morning sickness. Okay, morning sickness, quite common during pregnancy. There is increased skin pigmentation. You already know this. Increased skin pigmentation. Okay. In the last class, if you remember, we talked about linea nigra. Linea nigra. Okay. This is pigmentation of the midline of the abdomen, mainly below the umbilicus, but it can also occur above the umbilicus. Okay, that linea alba, we say that linea alba is darkly pigmented, and that is called linea nigra. This is one of the good example here. Another is skin striae. Stria gravidarum. Stria gravidarum is the term. Gravidarum means pregnant lady. So that is also one of the presumptive sign we can talk about. Now, what are the probable sign? See here, look at the list here. Meanwhile, I'll accept some of the students. See there, please. Now see here, the probable signs would be, okay, the probable signs would be related to uterus or mother's feeling, like enlargement of the uterus is one of that. The uterus is gradually increase in size. In this class, we'll talk about that after the first trimester, where is the height of the uterus, okay, around 20 weeks, where the height reaches, at 28 weeks, where it reaches, and at term, where it reaches. We'll talk about this very important knowledge. Maternal sensation of uterine contraction of fetal movement, absolutely important. We ask this question all the time during the antenatal checkup. We ask, what is the first time? When is that? When you feel the fetal movement? Okay, we'll ask like that. And that sensation of fetal movement for the first time is called quickening. Okay, which comes a little bit later in primigravida and earlier in multigravida. In primigravida, it may take 18 to 20 weeks of gestation. In multigravida, maybe 16 to 18 weeks. Hager sign is the softening of the junction between the corpus and cervix of uterus. Corpus means body of the uterus. Corpus is the term for body. So the junction between body and cervix of the uterus, there is a slight softening. This is called Hager sign. This is known by per vaginal examination. There is positive urine or serum beta HCG testing. This is one of the confirmatory, test or investigation we can say for the pregnancy. Now you may be wondering why it is not included under positive one, because there are certain other conditions which also release beta HCG, not only pregnancy. That's why it is noted as a probable sign. Remember this, okay? Now some of the students may be wondering what are those other causes of HCG secretion. Now you are going to answer this question. I just want one cause where HCG is secreted and that is not pregnancy. What is that? Anybody?
It's maybe choriocarcinoma or hereditary palm mole.
High level of HCG in choriocarcinoma, hereditary form, mole.
Very good. Very good. Very good. Excellent. Okay. I'm sure other students also know this. And these are the correct answer. Haida TD for mole and choriocarcinoma. These are the two pathological conditions where HCG is highly, means high level or amount of HCG is secreted. And you can also answer like a gonadal tumor. Any other type of gonadal tumor can also lead to HCG secretion. Very good. Let's move on. Now, if they ask you, what are the positive sign of pregnancy? Positive sign means definitive sign. Now, these are related to the fetus. That means there is a developing fetus inside the uterus. Okay. One of that is fetal heart tone. If we hear fetal heart tone, okay, by ourselves, there are different ways by which a fetal heart tone is heard. Okay, this class is all about that, but right now I like to explain this for you. Fetal heart tone, FHT, can be heard by one special instrument known as fetoscope. Okay, it is a stethoscope like instrument which is kept on the abdomen of the pregnant lady, and we can hear the fetal heart rate or fetal heart tone. Fetoscope. Another is Doppler. Okay, Doppler ultrasound. The Doppler can even play the sound of the heart beating. That sound can be heard. That is Doppler. And third, your own stethoscope. Okay, your own stethoscope that can be used to hear for the fetal heart tone. And if we hear fetal heart tone, this is the most important evidence that fetus is there inside the uterine cavity. Another one is ultrasound. Sonography means ultrasound. There is ultrasonographic visualization of a fetus. That is another important point for us. It also, confirm, yes, fetus is present inside the uterus. Another point, perception of fetal movements by an external examiner. For example, I am the examiner and I am palpating the abdomen of a pregnant lady. Okay, I can feel the fetal movement there. That is also very, very important one. And though it is theoretically written here, but practically we never do. That is X-ray showing a fetal skeleton. Okay, if it is done, it is a confirmatory one. But there are a lot of harmful effect of X-ray during pregnancy. That's why we do not go for this. So this is just a theoretical importance. These are different points regarding positive signs of diagnosis of pregnancy. Now let's move on. Okay. Now this is the ultrasonographic, diagnosis. Okay. Once again, very early in life. Okay, probably in 6 to 8 or 8 to 10 weeks of gestation, this is how they confirm whether pregnancy is there or not. They measure the crown rump length of the embryo. This is called crown rump length. Okay, crown is the, you understand like this, this is the head end of the embryo. Rum means this is the tail end of the embryo. So it is measured, and they can say yes, the embryo is there inside the uterine cavity. So this is one of the ultrasonographic diagnosis. Now let's summarize once again what we have talked till now. Okay, so here these are the important signs of pregnancy which the students can remember. Presumptive, these are unrelated to uterus or fetus. One of the important one is amenorrhea, and without amenorrhea we don't think about pregnancy. Okay, this is an important point. The menstrual cycle has to be stopped. This is called secondary amenorrhea. Probable means increased uterine size and beta HCG, the important one we have taken. Gradually the abdominal size is increased because of the enlargement of uterus. And definitive, we do ultrasonography to confirm whether baby is inside or not, and we try to hear the fetal heart tone by different things, like by fetoscope, by your own stethoscope, or even by Doppler ultrasound. So revise this, okay? Very catchy question during examination. Now let's move on. Another important part of this lecture is how to establish gestational age. Now, why it is important? Let me clarify this for you. Sometimes what happens when a lady comes to us for antenatal visit, antenatal means before the birth, or when she is pregnant, she will come to the hospital for checkup. That is called antenatal checkup, and this is my next class, not today, but maybe some other week. Now, we ask certain question. We ask about the last menstrual period, LMP, okay, last menstrual period, and many of them, they know it. They know exactly when is their LMP, but some of the lady, they don't know because their cycle is quite irregular from the beginning. Okay, if the cycle was 28 days long, okay, the menstrual cycle, the whole menstrual cycle I'm talking about, not the period, okay, the whole menstrual cycle 28 days long, then everything will go according to the book, whatever is mentioned in the book, everything will go smoothly. But if her menstrual period or menstrual cycle was irregular, sometimes 35 days, sometimes 30 days, sometimes 32 days, then okay, probably last menstrual period was also a little bit haphazard. And then what is the expected date of delivery? That also will be a problem. And what is the gestational age? The calculation is also a problem. So let's talk about this in this class. So how we exactly know. Okay, now see here. Now there are different ways. One is called conception dating. So we ask about, okay, the day of conception. Now day of conception means day of fertilization. Now that is very difficult, for that lady to answer. Many of them, they don't know. If they know the day of conception or fertilization, or the day of coitus, we say, it is 266 days from that day, or if you convert that into week, it will be around 38 weeks. Now see there, after 266 days, probably the expected date of delivery will be there. We don't need 280 days here because it is a day of conception. This is not a day of last menstrual period. The 2 weeks have already gone by. Okay, that's why it is 2 weeks less here. It's quite a easy things to understand. But the problem is many of them, they cannot identify the conception date, or they don't remember it. Another is menstrual dating. Menstrual dating is the one which we discussed already before. If the cycles are quite regular, that is 28-day cycle, then if she remember her last menstrual period, just after 40 weeks or after 280 days, okay, her expected date of delivery will be there. That is 280 days or 40 weeks. Now there is one rule which the student already know. Okay, what is that rule? That is called Negel's rule. What that Negel's rule will tell us. Assuming this cycle is a 28-day cycle, the due date can be estimated as two different ways. Okay, one way which we have already discussed. So let me start from that, okay? Otherwise you will be confused why we are talking the new things here. So what we discussed before, the expected date of delivery is, okay, LMP, then we add 9 month, okay, we add 9 month there, and we again add 7 days, isn't it? This is the way we have learned before. But let's go, what is the exact Negel's rule is all about? This is also, you know, one of the way of description of Negel's rule itself, okay? This is not new things, but what is that Negel's rule is all about? First, determine the first day of last menstrual period, that is LMP. Then count back 3 calendar month from that date. Means go back three month, okay? Go back, count backwards. Lastly, add 1 year and 7 days to that date. So exactly it is the same meaning if you pay attention for a moment. So here we are already adding 9 months and 7 days. And in the Negel's rule, what is described by that person, what he said is, go back 3 months first, okay, add 1 year and 7 days onto that. So exactly the same thing, okay? Don't get confused. You don't need to, start calculating by the Negel's rule. You can still follow the same one, that is EDD equals to LMP plus 9 months plus 7 days. But remember one thing I like to highlight again, this can be done only when the cycles are quite regular, that is 28-day cycle. Now the question comes immediately, what we do if the cycles are shorter or longer than 28 days? So let's talk about that. Okay, now see here, wait. Okay, now see here. Now, before we go with that type of discussion, one small things, otherwise we'll miss this later, is basal body temperature measurement. Now, what do you mean by that? After ovulation, there is release of progesterone. Now, in small question, from where progesterone hormone comes? From where?
Corpus luteum. Corpus luteum.
Very good, very good. All of
Corpus luteum.
very good, very good. It is corpus luteum, and that corpus luteum is formed after ovulation. That's what we are talking right now. So that corpus luteum will secrete progesterone, and this progesterone will slightly, okay, raise the body temperature in that lady. Okay, that is called rise in basal body temperature. Now, if she has the habit of measurement of temperature, then only she will know it. Otherwise, who will bother to measure temperature every day, isn't it? So this is just a theoretical one again. If she measures the temperature every day, then probably she exactly know when is the time of ovulation. Then from that time also, we can estimate, okay, the expected date of delivery and gestational age. Now, the accuracy of basal body temperature is plus or minus 1 week for the estimation of gestational age. Plus or minus 1 week, just like any other. Now see here, we are going to a little bit complicated type of thing, but please listen carefully. I will try to make it as easy as possible. Now, a little bit about the menstrual history. In this case, if the menstrual history is not exactly 28 day, if it is 35 day, if it is 25 day, if it is even 21 day, then how we calculate or establish the gestational age or expected date of delivery? Now see here, in that regard, what we assume is ovulation occurred on day 14 after the first day of the last menstrual period. Okay, but this happens in 28-day cycle. So 28-day cycle means, you know, is exactly middle, isn't it? 14 days. So 28 minus 14 is exactly on the 14th day the ovulation occurs. Easy, no complication at all. Now see here, The normal menstrual cycle can vary from 28 to 35 days, making ovulation possible on day 7 to day 21. Now, why ovulation can occur even on day 7 if a lady is having cycle of 21 days? Just now I told you, you have to decrease or subtract, I should say, 14 from the length of the cycle. So if the cycle length is 21, I have to subtract 14. That is the day of ovulation. So on that regard, it is day 7. If the length of the cycle is 35 days, subtract 14 from 35, it will be 21. Okay, so let me write once again here. You have to understand this, otherwise it will be a problem later on. If the length, here, if the length of cycle is 35 day, you want to know when is the day of ovulation, just subtract 14 from there and it will be 21st day. So this is the day of ovulation. Day is the day of ovulation. The day of ovulation. Similarly, if her cycle is 21 days long, then 21 minus 14, the ovulation day is 7. This is the one what I want to highlight here. Let me admit some of the students here. Okay, fine. Let's move on. The same thing. Okay, now see, all of you, please focus on your screen. The same thing is explained there again. So I'll give you a little bit of time so everybody will focus there. See there, please. Sure. Okay, you have a clear idea now. So see there are 3 examples given on this slide. This is a 4-week cycle, means 28 days. So the 2 weeks of proliferative phase, ovulation occurs exactly on day 14, and 2-week luteal phase. Luteal phase means secretory phase, where progesterone hormone is secreted. Proliferative phase is the phase where estrogen hormones is secreted. Okay, so this is the meaning. Now, another example for you. This is a 3-week cycle, a 28-day cycle. So I already told you on the 7th day the ovulation occur. So proliferative phase means before the period of ovulation, and luteal phase occurs after the period of ovulation. So luteal phase is 2 weeks here, but proliferative phase is only 1 week. That is the difference. If her cycle is 5-week cycle, means 35 days. See there, ovulation occurs on day 21. She has 3-week proliferative phase and only 2-week luteal phase. So luteal phase is constant, okay, whatever the length of the cycle, it is normal, shorter or longer. Now let's talk about something else. Now accordingly, if we want to calculate the gestational age or expected date of delivery, which is also known as due date, okay, due date. So accordingly, it may differ. What we have taken the reference, is it the fertilization date or is it last menstrual period? Okay, these are the 2 important points, isn't it? Fertilization date occurs after the ovulation. So already 2 weeks are consumed there. So whenever we talk about the expected date of delivery, it would be probably after 38 weeks. But if we talk about LMP, then we have to add the whole 40 weeks there. Okay, and along with that another 7 days as well. So you can see this on your own. Sometimes, okay, sometimes the due date comes later than the calculated due date if you consider the fertilization date as the reference. Now let's move on to another very important part. Okay, now how to hear the fetal heart tones and what do you mean by quickening? Fetal heart tones and quickening. Let's talk about it. Now, fetal heart tone is first heard by Doppler at 10 to 12 weeks. So it can be heard as early as 8 to or 10 to 12 weeks, sometimes even 8 to 10 weeks. It depends. So 10 to 12 weeks. That means we can exactly diagnose the pregnancy by this time with the help of Doppler ultrasound. They are first heard with fetoscope auscultation at 18 to 20 week. Now see that fetoscope takes time because the body of the baby has to be formed well, and then we will attach that fetoscope on the abdomen of the pregnant lady and then hear the fetal heart rate or fetal heart tone. So Doppler much earlier than the fetoscope. Maternal report of quickening. Now what do you mean by this? Okay, please pay attention. Quickening is the first perceived fetal movement by the mother. The first time when she feels that fetal movement inside her, that is called quickening. She will never forget this. Okay, she will never forget this, especially in case of primigravida. Okay, because that is a special time for them. First time when they perceive or feel the fetal movement. Even multigravida lady, okay, that is a special moment for them, definitely. So when is the time for that? It is 16 to 18 weeks in a multipara and 18 to 20 week in a primigravida. Multipara means she has already given birth, okay, multiple time, and primigravida she is pregnant for the first time. So it comes a little bit later in primigravida than in multipara. This is called quickening. Okay, so let's move on. Okay, now see that this is the Doppler. This is the Doppler which is used to hear the fetal heart tone. We can nicely hear the sound there. Okay, the beating of the fetal heart. Then we almost confirm, yes, this baby is still surviving inside. This is very, very important. When she complained that I cannot feel the movement of my baby inside for the few days, okay, and when she comes to the hospital and when we hear this fetal heart sound, okay, with the help of Doppler, this is very, very relieving for everyone, for that family, for the doctor, for everyone. Now, another important point, what was I was talking before, is the fundal height, okay, or the uterine height. So please pay attention here. This is very important knowledge for all of us. See here, this 12 means 12 weeks of gestation, 16 week of gestation, 20 week, 24, 28, 32, okay, 36, and 40. Now, some of the questions are really important here. After it crosses 12 weeks, then only, okay, it is coming above the symphysis pubis. So probably before that, there is no enlargement of the abdomen. Okay, we cannot detect the enlargement of the abdomen before 3 months. After that, it is rapidly enlarging. See here, it comes around the level of umbilicus at 20 weeks. This is important one for you. Okay, 20 weeks. At 36 week, see here, it is almost touching gyphoid process or gyphisternum. And at 40 week, it is again coming down than 36 week. Now, I want to ask you one question here. Why at 40 week it is coming down and not going up? Who can answer me that?
Because of lever.
Yes, because of labor. Okay. Any
Because
other answer? Yeah.
and sir,
Because
sir,
reduces of amniotic fluid.
Amniotic fluid reducing, sir.
Okay. Amniotic fluid gets reduced. Very good. I agree with you. Nice. Any other?
Because of two reasons. One is amniotic fluid decreases, and another is uterus start contracting.
Okay. Now see that. You know, you are giving me very good reasons, but let's combine all these together and your answer would be there. Okay. Now listen here. What happens when she reaches term? Absolutely correctly. The uterus starts to contract a bit forcefully or vigorously, and that is called labor pain. Now that will push the baby downwards, and the head of the baby will enter into the pelvic cavity. Okay, head of the baby will push or enter into the pelvic cavity. This is called crowning. Okay, the head would descend downwards, and if head would descend downward, the whole baby will be descended downward. So the fundal height will also be lesser than 36 weeks of gestation. And absolutely, you can give that reason. The amniotic fluid volume gradually decreases after that. That can be very well considered as another reason. So please revise this. The favorite questions here. At 36 week gestation, it would be the highest, almost touching the G-sternum. At 20 weeks of gestation, it is just reaching the umbilicus. And after 12 weeks of gestation, it is coming above the pubic symphysis. Now, according to the gestational time or weeks, okay, these are the fundal height above the symphysis pubis. Now see here. Now we never ask a question like this. Okay, this is all about the measurement, but you can clearly see here that these are the important points. Now, what about the ultrasound dating? What about the ultrasound dating here? What ultrasound would tell us regarding the expected date of delivery as well as gestational age? Now, first trimester ultrasonogram dating uses measurement of the crown rump length. I've already showed you that one picture, which is measuring CRL or crown rump length, and that is the most sensitive for the assumption or assessment of gestational age. Now, if your teacher asks you, one lady has come to the hospital, she doesn't know her LMP or last menstrual period. So I cannot use that Negel's rule for the estimation of gestational age now. I cannot do that. Now, what is the other way? Okay, the one other way is ultrasound. So let's do ultrasound in the first trimester around 8 to 10 weeks. That ultrasound will tell me almost surely, almost correctly, what is the gestational age or what is the expected date of delivery. But if the same lady comes in the second trimester or third trimester and the ultrasound was never done in the first trimester, then the sensitivity of that ultrasound in confirmation of the gestational age is not much higher. Okay, the sensitivity is gradually decrease. Now see here, in second and third trimester ultrasound, sonogram is ultrasound. Which of the measurements are used to know what is the gestational age of the baby? These are biparietal diameter, which is called BPD, biparietal diameter, circumference of the head, abdominal circumference, and femur length. These are the four things which that ultrasonologist will measure all the time. Okay, if you have some of your family member, maybe your sister or somebody else, or maybe they're pregnant and they have gone to the hospital and done the ultrasound, please make that habit of reading that ultrasound report now. These measurements or diameter are always shown there whenever they do ultrasound in second and third trimester. Now, what is the accuracy of this ultrasonographic dating, okay, in comparison to the other. I already told you this. If it is done in the first trimester, okay, it is as accurate as other measures. But if they are done in the second or third trimester, then the sensitivity of that ultrasound report will drastically decrease. Now see there, this is crown rump length, okay? Crown rump length at 8 to 12 weeks. See this. This is how they measure. The ultrasonologist, this is the ultrasonographic picture, and dating accuracy is plus minus 5 days. This is the very accurate one. But at the same time, if we do this type of ultrasound in the second and third trimester, the dating accuracy decreases. Now, before, okay, I stop this class and go for the break. See here, variation in ultrasonogram accuracy for the due date. Under 12 weeks, plus or minus 5 days. 12 to 18 week, if we do ultrasound at this time, okay, that is the point, plus or minus 1 week. 18 to 24 week, plus or minus 1.5 week. 24 to 30, plus or minus 2 week. 30 to 36, 2.5 week, and 36 to 40 week, plus or minus 3 weeks now. This is very less sensitive in comparison to the first one. So that's what, okay, I mean by discussing this ultrasonographic accuracy. Now let me remind you once again why we are talking. If the lady remember her LMP, well and good. If she doesn't, these are the way. So now let's talk about what are the normal pregnancy event first, and then what are some of the common complaint or some of the common problem felt by the pregnant lady during pregnancy. So let's talk about the normal pregnancy event first. See there. During first trimester, okay, during first trimester, what are the common pregnancy event? Now, assuming a 40 menstrual week pregnancy, the first trimester is assumed to extend from the conception through the 12 completed weeks. This is first trimester. So the common or normal symptom that the majority of pregnant lady feel during first trimester are nausea and vomiting, which is known as morning sickness. Okay, nausea and vomiting or morning sickness, easy fatigability, breast heaviness or tenderness, and frequent urination. These are the normal symptoms. They are considered as a normal phenomena or symptoms during first trimester of pregnancy. Now, if they are excessive, then only we have to do something. Otherwise, they are considered a normal event. This is the meaning. Spotting and bleeding occur in around 20% of the pregnancy during first trimester, and 50% of which will continue successfully. Means slight amount of bleeding may occur in 20% of the pregnancy during first trimester. Some of them are called implantation hemorrhage. When that embryo, okay, or fertilized ovum or zygote, whatever you want to say, is implanted, okay, on the endometrium, slight amount of bleeding can happen, but still the pregnancy would continue in many of them. Average weight gain during first trimester is 5 to 8 pounds. Average weight gain during first trimester is 5 to 8 pounds. What is the relation between kg and pound? Anybody? Now that is a bit,
7 kg is equal to 2.2 pounds.
Yeah, absolutely correct. 1 kg is equivalent to, okay, 1 kg, sorry, let me write it here for you. 1 kg is equivalent to 2.2 pound. So kg is a heavier unit than the pound. Now, a little bit, like 8 pound is roughly 3.5 to 4 kilo. 3.5 to 4 kilo of weight gain occurs during the first trimester. Now, when we, talked about second and third trimester, then at the end, you need to calculate how much is the average weight gain by a pregnant lady, okay? So please make a note of this. Complications during first trimester can be if there is excessive nausea and vomiting, especially the vomiting, okay? This is called hyperemesis gravidarum. We'll talk about that later. Hyperemesis gravidarum. Emesis is vomiting. Hyper means excessive. Gravidarum is pregnancy. Very easy term. Hyperemesis gravidarum. That is one component, excessive problem. Another is abortion. In the first trimester, abortions are quite common, especially spontaneous abortion. Okay, because of chromosomal abnormality, so many ladies all over the world, they suffer from spontaneous abortion. But the prognosis is quite good, and later on they can become pregnant and can give birth to a healthy baby again. Okay, let's move on. Now, in the second trimester, what are the normal event now? Now, assuming a 40 menstrual week pregnancy, the second trimester extends from 13 to 27 week. Now, what are the normal symptoms? The normal symptoms are an improved feeling of general well-being. Okay, there's not much problem during the second trimester. She may suffer from some of the Braxton Hicks contraction. Now, see that. Please focus here. These are the important term for your future exam. Braxton Hicks contraction. They are painless. Okay, low intensity, long duration contraction of the uterus, and they can be palpated or felt as early as 14 weeks of the gestation. So Braxton Hicks contraction, they are not labor pain. Please don't get confused. Okay, they are a painless low intensity contraction which is felt by the pregnant lady, especially in the second trimester, as early as 14 weeks. Another very important phenomena occurs during the second trimester, that is quickening. Now quickening, you already know now, is a maternal awareness of fetal movement for the first time. It is detected at 18 to 20 weeks, okay, by primigravida, and 16 to 18 week, I can say, by multigravida. Multigravida or multipara, they feel it earlier than the primigravida. So this is called quickening. As a PDS, as an obstetrician, I should say, while we take the history, we can confidently ask about quickening, and many of them, they remember it because this is one of the important event. Now, what is the average weight gain in second trimester? Now see there, 1 pound per week after 20 weeks. 1 pound per week after 20 weeks, okay? And before 20 week means after 13 to 20, it is near about 1 pound. Not exactly 1 pound, but a bit lesser than that. Now, regarding the complications, what can happen during the second trimester? Now, what are those? See here. Now, the complication during the second trimester would be cervical incompetence or incompetent cervix, which may result in birth of the baby, and this is one of the cause for abortion. If it occurs before 20 weeks, it is still called abortion. Always remember that. But after 20 weeks, if the birth of a dead baby occurs, this is called stillbirth. So there is a slight difference between these. Incompetent cervix is a common cause of abortion or stillbirth during second trimester. Another complication can be premature rupture of membrane or even premature labor. Okay, let's move on. What happens during third trimester? What event are called normal event during third trimester, and what are some of the problem? Now, third trimester starts from 28 up to the 40 weeks. And normal symptoms include decreased libido. Okay, decreased libido means decreased urge of sexual contact, that is called decreased libido. This is because of the hormones. Lower back and leg pain, quite common because the fetus is rapidly increasing. Okay, the fetus is rapidly increasing, the uterus is rapidly enlarging, the uterus may give pressure to the lower back, okay, pressure to the inferior vena cava, there may be congestion and edema around the lower limb. So everything is going on side by side, so there will be a bit of more problem in that lady. Urinary frequency will increase and Braxton Hicks contraction would continue. We already know that. Okay. Now, another important, phenomena occurs during third trimester, that is lightening. Now, this lightening means descent of the fetal head into the pelvic cavity, which results in easier maternal breathing. Okay, easier maternal breathing, and at the same time she feels excessive pelvic pressure. Now let me explain this in an easy way. Now see that I already told you, after around 36 to 37 week, the height of the uterus is maximum. It may even reach the xiphoid process, and sometimes it is even pushing the diaphragm upward. But if diaphragms are pushed upward, they may push the lung. So there will be a bit of breathing difficulty. But after the baby descends downwards into the pelvis, suddenly that pressure against the diaphragm would be no more. So lady would feel relatively slightly easier to breathe. This feature is called lightening. It is called lightening. Okay. At the same time, she feels pressure in the pelvic cavity now. Another important point is show. Okay. Now, what do you mean by this? See here. Now, show, also known as bloody show, okay, usually show has got a bit of blood in it, describes the vaginal passage of bloody endocervical mucus. Okay. So see there, during pregnancy, the inner canal of the cervix. Now let me talk a little bit about cervix here. Okay, cervix has two opening. One is the external os, another is called internal os. In between the external and internal os, there is cervical canal. Now this cervical canal is blocked by a mucus plug during pregnancy. Now, what happened near to the labor time or delivery time, when the labor pain starts, okay, this endocervical mucus plug will come downwards towards the vagina with a bit of blood. This is called show or bloody show. So this can happen in third trimester. And average weight gain in third trimester is a pound per week. Okay, after 20 weeks, so it will continue in third trimester also, the same thing. So these are some of the events which occur during third trimester. Now, what complication can happen during third trimester? So please have a look there now, all of you. Pay attention on your screen. So the complications are premature rupture of membrane again. Okay, after that, the amniotic fluid will gush outwards. Okay, a lot of problems can happen. Premature labor can start. Preeclampsia can happen. Now this preeclampsia is hypertension during pregnancy. Okay, along with some proteinuria. It's a part of preeclamptic toxemia also. UTI, anemia, and gestational diabetes. All of these can occur during third trimester. All of these are important topic in obstetrics, especially anemia and diabetes. We'll talk about that in the coming classes. So these are some of the complications. Let's move on. Now, the remaining part of this class is about what are the discomfort related to the different system by the pregnant lady now. Okay, so we have divided this under different systems, and let's talk about that. And these are very common problems, so that as a doctor, if a pregnant lady who is there inside your family or in your neighborhood has come to you and asks, you can very easily give suggestion or even advice for the treatment, or advise a solution where they will go for the treatment. So please pay attention here. The first one is morning sickness or nausea and vomiting. I already told you this is considered as the normal process or normal phenomena during pregnancy, but we need to know how it happens, what is the mechanism, and if it is excessive. Sometimes it is excessive, okay? So what should we do? One of the most common discomfort of early pregnancy is, okay, morning sickness. This occurs due to high levels of HCG or human chorionic gonadotropin hormone. See here. So you have already got the point. If the level of HCG is higher, okay, than the normal, there is more chance of having morning sickness. Okay, HCG is producing progesterone, so they are related with each other. Okay, and some of the cultural expectations and emotional factor is also making that lady doing for the morning sickness. Okay, so let me clarify a little bit on this. Inside the family, okay, if daughter-in-law is having nausea and vomiting after the marriage or wedding, maybe after a few months or maybe after a few years, then the mother-in-law and other family member believe, oh, she is pregnant now. These are called the cultural expectations. Okay, so that's the meaning. Now, nausea and vomiting usually appear early in the first trimester. Early, they are quite early, around 6 to 8 weeks, and they are considered as one of the symptoms of pregnancy, and they subside by the end of 12th week of pregnancy in many of the pregnant ladies, but in some of them they continue even till the second trimester. Okay, and that is called hyperemesis gravidarum if it is excessive. Now see here, what are the interventions that consist of advising the mother to? What should we advise her if she complain about this? Okay, if there is a little bit more type of morning sickness, more amount of nausea or vomiting, what should we tell her? Eat a high protein snack at bedtime if it is a hypoglycemic attack. So a bit of more proteinous diet would be fine. Okay, eat crackers or a piece of dry toast before getting up. Eat frequently spaced small meals of high quality proteins and sip a hot drink before arising. So these are the different things we can tell her. See, it's a bit about protein. Okay, protein will not cause that increase amount of morning sickness. Carbohydrate and fat, probably they will have more impact. Now, if these simple measures fail, we can prescribe anti-emetic. Now, can you tell me what are the examples of anti-emetic drug, guys? Yes.
Metoclopramide, dexamethasone,
Chlorpyracid,
Ondansetron,
cyclizine, and
Very good.
ondansetron, denicetron, belonosetron, and chlorpyracid.
Exactly. I got your answer. Very good. So exactly. So every student know that at least one or two examples. Okay, metoclopramide, domperidone. These are very commonly used. Okay, if ondansetron can also be tried, but it is more commonly used in anti-cancer drug therapy. Okay, even antihistamines can act as anti-emetic agent.
Cyclizine and protamazine, sir.
Exactly. You're right. Yeah. Now, another common complaint during the pregnancy is heartburn. Now, heartburn is a layman term. This heartburn is a burning sensation in the epigastric region and in the sternal region due to GERD or gastroesophageal reflux disease or due to reflux of stomach content. So every student know that. Now see here. So this is due to reflux of the stomach content during the pregnancy. That's what we are talking right now. And there are certain interventions which we advise to the patients, like eat frequent small meals. Taking a big or heavy meal at a time and making that stomach quite full, okay, is not a good thing in case of heartburn. It will further aggravate the situation. Rather than that, we'll advise frequent small meal. Take sips of milk or hot tea. Okay? That is a soothing. Eat a bit slowly. Avoid fatty and gas forming food. Okay, all those gas forming drinks and the fatty foods are not allowed or are not encouraged during this time. One very important point is maintain a good posture, okay, to give the GI tract a lots of space. Now, what do you mean by that? Do not completely lie down after eating. Okay, rather than that, a bit of, okay, using a bit of pillows, maybe 2 to 3 pillows, okay, and leaning against those pillows would be a nice thing to do. Okay, lying immediately after taking a heavy meal is not a good idea at all. So these are some of the important points. If simple measure fails, you need to prescribe antacid. These antacids are, isn't it? They are very simple type of medicines in the treatment of hyperacidity. They neutralize the acid. Now, another important complaint or the problem during pregnancy is constipation. Now, many students know this already. We have discussed this before. And I asked certain questions also regarding this. Now, let's talk a little bit in detail regarding this. During pregnancy, because of the release of progesterone hormone, which is relaxing the smooth muscle, there is decreased GI tract motility. This is the first thing you need to understand. The GI tract is made up of smooth muscle. Progesterone will relax the smooth muscle, so GI tract motility is slowed or reduced. That results in, okay, decreased peristaltic movement. Now, whatever content is there inside the colon, okay, that content will remain there for a longer time. So increased reabsorption of water occur from the colon, resulting in drying of the stool. This is one of the very important mechanism of constipation, probably the most important mechanism here. Another mechanism is compression of the intestine by the enlarging uterus. Students know that also. Okay, so these are some of the important points. Now, what this constipation will do during pregnancy? Now, this constipation do certain things there. One, this loaded colon will give pressure to the ureter, and ureter undergo stasis of the urine. That stasis of the urine may predispose to urinary tract infection during pregnancy. This is described in many textbooks. So constipation we need to treat if it is bothering to that lady. Now, another cause of constipation during pregnancy, especially during pregnancy, may be because of iron therapy or iron supplementation. Iron is one of the drugs which we give very commonly to the pregnant woman. Okay, so that iron has a constipating effect. Now, what intervention, okay, we advise to the patient? Drink at least 6 glasses of water per day, because drinking enough water is a very good suggestion or advice we can give to the constipated patient. Okay, enough water should be allowed. Increase the fiber content in the diet. that is called roughage in the diet. Increase fiber containing diet. Okay, that should be increased. For example, bran, okay, coarse ground cereals, fresh fruits and vegetables with skin. Fresh fruits and vegetables with skin, they are the wonderful one along with the water. And along with that, okay, some coarse type of cereals. Do moderate type of or amount of exercise every day, especially walking. Okay, don't sit in one position for a long time. Maintain a regular schedule for bowel movement. So every morning you need to even try for that, and utilize deep breathing and relaxation technique. These are some of the way we suggest in a case of constipation during pregnancy. But remember, the important points are enough liquid or water and fiber containing diet along with some mobility or exercise. These are the important thing which we prescribe or advise. Drugs are not usually given because it is said that it will form a habit. Only after taking the drug or medicine the lady will go to the toilet, otherwise she will further have aggravation of constipation. But if it is really necessary, we'll definitely give. I'm not saying that, okay, but it is not encouraged. Now, what are the discomforts related to the musculoskeletal system? Please do not talk. Okay, I muted all of you because that student was not listening at all. Now, another complaint is backache. Okay, backache is very common complaint during third trimester of pregnancy, especially third trimester. Backache is very common. Now, that backache is caused by relaxation of the many joint or the ligaments, okay, which are holding that pelvic cavity there. Now, one of the important joint is called sacroiliac joint, which is due to increased hormone. And one of the hormone which I was taking the name when I taught you about the different hormones secreted during pregnancy, that is relaxin. Okay, this relaxin comes here. This relaxin is relaxing all the joint, ligaments, tendons, whatever are there near to the pelvic cavity. Okay, and that will cause a bit of backache. Increased mobility, okay, and exaggerated lumbar and cervical thoracic curve. So see there, exaggerated lumbar and cervicothoracic curve caused by changes in the center of gravity, and this center of gravity change occurs because of enlargement of the abdomen and even the breast. Now let me explain this in an easy way for you. During the pregnancy, because of the large abdomen, okay, and because of the heaviness and enlargement of the breast also, there is formation of lordosis. Okay, let me write it here for you. This is called lordosis. Okay, usually lumbar lordosis is very common during pregnancy. A bit similar to the obese person. Okay, because of the big belly, the obese person will also develop lordosis, the similar type of situation here. Because of that, backache is quite common. So what are the intervention we can advise to that lady? The interventions are practice good posture and good body mechanics. Okay, good posture and good body mechanics. Like, what do you mean by that? See here. Okay, 1 minute. Okay, see there. Good body mechanics means use the pelvic tilt and bend at the knee. So the position, she should not stand most of the time. Probably she should sit on a particular area or place and give enough rest to the pelvic cavity and the lower vertebra. That is the meaning. To wear appropriate and well-fitting shoes. It is really soothing for the lower limbs and even the lower back. At night, sleep on a firm mattress or backboard, not in a very soft type of a mattress. A firm mattress is always preferred if somebody is having backache or back pain. This is not only for the pregnant ladies, for anyone. If they have the complaint of backache or back pain, remember this. So many members in our family also having the similar type of problem. Please suggest the use of firm mattress to them. Okay. And one thing, some medical problems can also lead to backache. And some of the examples are kidney or bladder infection, or sometimes even the stone formation there. So all of these has to be noted. And if you think there is a chance of infection, then urinary examination has to be done and UTI has to be ruled out. If all of these are not helping, then application of local analgesic can be done. And if this is also not helping, then we can prescribe some paracetamol to that lady. Other drugs are a bit relatively contraindicated. Remember, do not prescribe NSAID just like that, like in other periods of life. During pregnancy, NSAIDs are not preferred, but paracetamol is considered a bit safe. Okay. Now, another very common problem is a muscle cramp. Muscle cramp. Now, before going into this slide, let me ask some question to you guys. Now, sometimes we also get very painful type of muscle cramp or muscle spasm during the night time. So what may be the common causes of muscle cramp or muscle spasm? Anybody? Okay, let me unmute you because one of the students was making a lot of noise. So yes. Now, can anyone tell me?
Maybe nerve compression.
Abnormal nerve activity. So in some cases, the tendons get shortened with age, so that can also be a factor. Sir, improper sitting positions, such as prolonged standing. These can be some causes.
The wrong posture of sleeping, sir.
Okay. Now see there. I already got the answers. Some of the students saying probably because of the nerve compression. Yes, that is one of the good thinking from your side. Another maybe prolonged standing or prolonged exercise or something like that during the daytime. Okay, but all of them are not very important if I think about electrolyte disturbances. Electrolyte. And one of the important electrolyte in this regard is sodium and calcium. In case of sodium and calcium imbalance in the body, there is increased chance of muscle cramping. So remember, if you are having those type of things, probably you need to drink more milk. You need to take more calcium containing food or even calcium tablet. And if you want to confirm whether you are really having hypocalcemia and because of these problems, go for checkup. Sometimes it may be a small reduction in the calcium level, but we are having these features, so it is not that harmful, okay, to take some calcium pills or tablets and increasing the calcium containing food. That's what I want to say here. Now, muscle cramps are not considered a serious condition, but they may be quite painful sometimes. So some of the important interventions we advise to the patients are avoid fatigue and cold legs. Okay, sometimes even the cold exposure can give rise to muscle cramp or muscle spasm. So a bit of warm or hot application would be good. Eat a diet with adequate calcium or prescribed calcium. That's what I was talking right now. Avoid drinking more than 1 quart of milk per day. More than 1 quart of milk per day will create too much phosphorus in the system. Now tell me, what is the relation between phosphorus and calcium?
Alkaline solution, you decrease the alkaline solution.
Yes?
So some high level of phosphorus causes hypercalcemia.
Exactly. Okay. Another student, sorry, I could not saw your name there. No problem. If we take excessive phosphorus, that excessive phosphorus will bind calcium and it leads to hypocalcemia. So too much drinking of milk, okay, is also not good. This is very, very true in children also. Now let me tell you a little bit interesting thing here. During the village side, okay, towards the village side, I should say, towards the village side, so many parents, they believe that if their baby drink milk, okay, probably 2 to 3 liters of milk a day, they will be very healthy. But actually some truth is there, but entirely it is not true, isn't it? There is not, you know, lack of balance type of diet. If the child is only drinking milk, probably the child is lacking in other type of food. That is one thing. And another, the reason what I am describing here, excessive phosphate or phosphorus in the milk will decrease calcium level in the blood. That is not good. So these are some of the important things regarding the muscle cramp. Now, some of the treatment we can give for the simple type of muscle cramp. This type of a little bit of help for the patient. Okay, stretching of the legs or stretching of the muscle, some maneuver are really helpful. You can clearly see here in the picture, and later on you can see what is the meaning of this. I don't need to explain this. Let's move on. Okay, we are coming toward the end of this topic. What are the discomfort related to the cardiovascular system? Let's see here. One of the problem is called supine hypotension, also known as inferior vena cava syndrome. Okay, this is inferior vena cava syndrome, and the reason for that is pressure of the gravid uterus on the ascending vena cava. Ascending vena cava means inferior vena cava, okay, and descending vena cava means superior vena cava. Sometimes different textbook mention it differently, so don't get confused here. So the pressure of the gravid uterus on the inferior vena cava when the woman lies supine on the bed, and that leads to decrease in the venous return. Decreasing venous return leads to decreased cardiac output and decreased blood pressure. So these are important point in supine hypotension syndrome. What are the symptoms of this? The symptoms include nausea, cold and clammy foot or periphery. The person feels like, okay, they are going to faint. Especially we are talking about pregnancy now. So those pregnant lady who are having supine hypotension think they are going to fall down or faint. And if we measure the blood pressure, it is decreased. Now, one small question which we have already done before. What is the difference in blood pressure during pregnancy and non-pregnant lady? What is the difference?
Blood pressure increases
Pressure.
during pregnancy.
Slightly decreased during pregnancy.
Now, there are two answers I'm getting here. Okay, so listen. Normally, okay, don't think pathologically all the time. Pregnancy, if this is a physiological condition, isn't it? No diseases, then the blood pressure usually decreases than a non-pregnant lady. Usually the diastolic blood pressure decreases more than the systolic. We talked about that. But another point you can add here, so many of the pregnant ladies, they develop a pregnancy induced hypertension, so blood pressure may be increased there. Okay, that is another point. Okay, so in the last class I was talking about some minor discomfort during the pregnancy. Okay, these are called minor discomfort or minor complaints during the pregnancy. Remember, pregnancy is a physiological condition or physiological state. So we still consider these minor things as a part of the normal pregnancy. But if they are excessive, if they keep on bothering the lady, okay, then we need to address them or we need to manage them. Okay, this is the concept. Let's move further. So one another condition which is quite common during pregnancy is varicose vein. Now in pathology you have already discussed this varicose vein probably in the last year. Now varicosity is an enlargement of the lumen of a vein due to thinning and stretching of its wall, or you can also say dilatation and tortuosity of vein is called varicosity or varicose vein. So in this condition the veins are dilated because of the thinning of the wall, and they become tortuous, okay, because of the stretching. Now it is caused by, we are talking about in pregnancy now, okay, it is caused by different pathophysiological factor. One of them is progesterone hormone. Now please mute yourself. One of the important factor is progesterone hormone. Now see here, this progesterone hormone will cause relaxation of the smooth muscle, and that relaxation of the smooth muscle leads to stretching of its wall and thinning, which can lead to varicosity. Another is, see there, enlarging uterus. Okay, this enlarging uterus in the pelvis will give pressure to the great abdominal vein. The most important of them is inferior vena cava. Now if inferior vena cava is compressed, there is decreased venous return, okay, from the lower extremity. So the blood will all the time remain there, and that excessive pressure to the inferior vena cava will increase the pressure inside the vein of the lower limb also, and that is one of the factor for varicosity. This is very easy to understand. Now, another one, it is also aggravated by gravity and bearing down for bowel movement, because in pregnancy constipation is very common. So that lady will strain probably, that is one of the aggravating factor. And if she stands for a longer time as a result of gravity, it is also aggravated. Now that's why if they ask you what are the causes of varicose vein, overall, not only in the pregnant condition, then you can say prolonged standing is one of the very important factor, like in farmers, teachers, and those type of occupation. It may be a hereditary predisposition as well. It may run in the family, but that is a bit rare. Now where the varicosity develops, it is of course in the lower limbs. Not only there, it also develops in the external genitalia like vulva or labia. This is labia majora, even inside the pelvis, or even in perineal area, which is known as hemorrhoid. So these are some of the important points regarding varicosity. Let's move on. Some of the students have not muted themselves, so I'll request once again, otherwise I have to mute all of you from here. Abir, she is not listening, and Tahir, okay, he has just done it. So we can see all the names here, okay, so please do it. That means the student is not there in front of the computer. Now what intervention, okay, a pregnant lady should do to treat the varicosity? Now the important intervention the pregnant lady should do are avoid the obesity, because obesity, okay, has an inverse relation with the varicose vein, means obesity will increase the varicosity. Avoid the lengthy standing or sitting. I just now told you the importance of lengthy standing, but also sitting with legs hanging. This is important one. If that lady sits for a long time with hanging leg, then also because of the gravitational effect, varicosity may develop. Avoid the constrictive clothing. This is another important point, because it will increase the pressure there. Avoid constipation and bearing down. Definitely elevate the leg when sitting. See that this is important so that the venous return will be proper. Get adequate rest and perform moderate exercise. These are the important points by which that lady can prevent the development of varicose vein. So this is important point. Let's move on. Now, what are the treatment once the varicose vein have already developed? She should take rest with legs and hips elevated. Now, this is to have the proper venous return. Important point. She should wear support stockings before rising. Okay, so this support stockings is to squeeze the vein. That is to squeeze the vein so that the blood will drain towards the heart, or it will return towards the heart. Another one, lie on the bed with the legs extended at a right angle to the body if ordered by the physician. So these are different things she can go for. Okay, and if it is very excessive, and even after the pregnancy, if it is still there, then surgical treatment can be done. Now, another important complaint during pregnancy is edema. Edema is swelling. Now, where does that swelling occurs? Okay, it is again very common in the lower limbs. Now, see here, edema is a very common during pregnancy. It's a common condition. It most often occurs during the second and third trimester. Now, why not in first trimester? Why in second and third trimester? Yes, anybody?
Because
Maybe
uterus
sir, due to
size is
amniotic
not
fluid increase.
Okay.
uterus size is not large in the first trimester, and in second and third uterus size is large, and which suppress the.
Sir, it is due to the increase in volume of blood and fluid in the body, sir, during the second trimester mainly, sir, because of amniotic fluid, other blood volume increase, sir.
Excellent. So I already got the answer. Very good. Though it is coming from the one point from the different students, but all of those are the correct answer. All of those. The amniotic fluid volume gradually increases. So the uterus size gradually increases during second and third trimester. The size of the baby is gradually getting bigger and bigger. So again, it will distend the uterus, and distended uterus will give pressure to the inferior vena cava. Okay, very important point. Then there is retention of excessive fluid during pregnancy. Remember, the plasma volume almost doubles up during pregnancy. All these are important points regarding edema formation. See here, edema is caused by reduced blood circulation in the lower extremities as the gravid uterus puts pressure on the large vessel. So this is important one. This reduced blood circulation, please do not understand it in the other way. It is not regarding the arterial circulation. It is regarding the venous return. The venous return from the lower extremities is poor. So the pathophysiology is a bit similar to varicose vein here. Now, sometimes if these signs are present, that means edema is not normal. It may be pathological, or it may be there because of some other conditions like proteinuria. Okay, proteinuria with edema is never normal. Who knows? It may be a feature of preeclampsia. Okay, preeclampsia is a condition where there is pregnancy-induced hypertension with proteinuria. This is also known as preeclamptic toxemia, PET. Okay, we'll take a big class later on. Don't worry, this is an important topic in obstetrics. But right now, you just understand this much. Now, edema of non-dependent part. If it occurs, it is never physiological. It is always pathological. For example, non-dependent part means face. Okay, face, isn't it? If the person, for example, is walking, and if there is ascites, for example. Okay, so all these things are important. Sudden increase in weight, okay, than expected. This is important point. In pregnancy, there is weight gain, no doubt about it. Around 8 to 12 kg is the average weight gain during pregnancy. Average, okay. Some of the ladies gain lesser, some more. We're talking about average now. So if there is a sudden increase in weight more than expected, it is also pathological. And hypertension, already talked about. Now, some of the intervention, okay, which are advised, some of the interventions which are advised are maintain good posture, avoid prolonged standing or sitting, wear the support stockings, avoid the constrictive clothing. See, all of these a bit similar to varicosities because the pathogenesis is almost the same. Okay, so no need of any explanation here. Drink at least 8 glasses of fluid for a natural diuretic effect, not more than that. Excessive drinking is also not good when lady is having edema. And get adequate rest and exercise. So these all are important points to decrease the physiological edema. This is physiological. Let's move on. Now, what are the treatment of ankle edema? Elevate the feet as often as possible. It will help, okay, to disappear that edematous fluid. Apply short support stockings before getting up. Stockings means it's a bit of compression there, and diuretics are contraindicated. Now, let me say a little bit about it, though many of the students know this. Diuretics are the drug which decreases our blood volume, okay, which decreases our blood volume, and by doing so, they may decrease the blood pressure. The pressure is already a little bit low here, though blood volume is high, okay. It is all about the pressure. If pressure is decreased, then the blood flow towards the placenta will suffer, and if placental blood flow will suffer, the baby will suffer. So all are interconnected with each other, and most of these edema are physiological, so diuretics are contraindicated. Now, which is the most potent diuretics, guys? Which group are the most potent one?
Acetylazomide, furosemide.
Okay.
Potassium sparing agent, sir. Thiazide.
Now see here, so students are answering the classification of diuretics. Okay, good. This is a very good knowledge to have. But if your teacher asks which is the most potent, means most strongest one, that is
Loop diuretics.
exactly
Loop diuretics.
exactly. Very good. Loop diuretics. Okay, loop diuretics are the most potent one, like furosemide. That is a perfect example. But you can remember the different classification. This question is very commonly asked by many teachers. If condition worsens to a generalized edema, the patient should notify her physician. Who knows? This generalized edema may be caused by nephrotic syndrome. It may be caused by heart failure. It may be caused by liver disease, okay, or maybe hypoproteinemia. So a proper investigation has to be done. Now, let's move on. Let's talk about what are the discomfort related to the respiratory system now during pregnancy. Now, that is dyspnea. Dyspnea is difficulty to breathe. Now, in internal medicine, I'm sure you are studying this right now, dyspnea. Now, if during pregnancy, dyspnea is complained by that pregnant lady, then we should find out the cause. But most commonly, the cause is physiological, and that physiological cause would be limited expansion of the diaphragm by the enlarging uterus. Means it will press the diaphragm upward, okay. It will give pressure to the diaphragm upward, and that dome of the diaphragm will press lungs. So there is limited expansion, okay, of the lung that can result in dyspnea. Another one, it may be an increased sensitivity to or compensation for slight acidosis, okay, slight acidosis, and this is called as breathing for two. This breathing for two means, okay, a baby is counted as one and mother is counted as another. So the two individuals, mother is breathing for both of them. That's why there may be a bit of dyspnea. Dyspnea may be very troublesome in the last weeks of pregnancy because of great enlargement of the uterus, and that is giving pressure to the diaphragm. So what intervention the lady can take? See here. Okay. So please mute yourself. I can still hear some noise from somebody's, Zoom. So she should do, sleep on additional pillow. Now, this is almost similar to orthopnea treatment. Now, anybody tell me what is orthopnea? What is orthopnea?
The edema will increase due to lying position.
Yes,
Increase of
please.
It is not rather difficulty breathing, sir, when you are lying down. Sir, when we are lying down in the supine position, sir, it's difficulty breathing or shortness of breath.
Good. Okay. Now see that many students, I'm sure about it, they know, but I cannot listen all the answers now because it will take a bit of time. So please, when I explain these things, okay, listen carefully. And even if somebody cannot listen because of the internet problem or something like that, I'll always provide you the audio, and even I'm uploading the video in YouTube. So follow them later on. I'm doing all these things for you guys. So orthopnea means, okay, ortho means flat. Okay, so if somebody is having difficulty in breathing when they lie down flat on the bed, this is called orthopnea. This is a very important symptom of heart failure, especially left-sided heart failure or pulmonary edema. Now, this is not a orthopneic condition here. But why I am bringing that point is just comparing the situation in orthopnea also, to have a bit of relief from that orthopneic situation. The patient will use multiple pillows and patient lie against that pillow. Okay, this is what they do at home. The same thing can be done by pregnant lady if she is having dyspnea during the last weeks of pregnancy. Maintain good posture, avoid overeating to avoid the over distension of the stomach. Stop or decrease smoking, because smoking will further decrease the lung function. That is the correlation. Limit activity before becoming dyspneic. Don't strain yourself. Okay, don't strain yourself. That is the point. And decrease anxiety by concentrating on slow, deep breath. Now, if somebody is anxious, all of you know that they breathe faster. Already there is tachypnea and dyspnea in pregnancy. If that pregnant lady is anxious, then dyspnea will even become more. Okay, so we should tell her there is nothing, no point to become anxious. Everything will be all right. So she should focus or concentrate on slow and deep breath. So that is a very, very important counseling. Now, dyspnea of sudden onset in patients who are having heart disease may be a sign of impending heart failure or pulmonary edema. During that time, she should not stay at home. She should quickly go to the physician or hospital and then get the treatment or get investigated. So it all depends on how severe and how fast the dyspnea has developed. Let's move on. Okay, another minor type of problem, okay, during pregnancy is nasal stuffiness. Nasal stuffiness means the pregnant lady feels like there is obstruction of the nose. Okay, there is obstruction of the nose. Probably the mucosa inside the nasal cavity is hyperactive. This is the meaning. So nasal stuffiness is caused by increased vascularization due to the increase in hormone level during pregnancy. There is increased blood flow inside the nasal mucosa. There is probably dilatation of the blood vessels inside the nasal mucosa, which is causing slight obstruction there. This is not preventable because the increased level of hormones are doing it. Okay, and a good counseling is necessary, and the functioning of nasal mucosa will return to normal after delivery because the level of hormone will come back to normal. Now, after respiratory system, what are the discomfort related to the reproductive system? Let's talk about it. Now, one of the important complaint by the pregnant lady during pregnancy is called leukorrhea. Now, leukorrhea means white or slightly yellow mucus discharge from the cervical canal or the vagina. So this is a mucus discharge from the birth canal. It is mainly white. That's why the term leuko means white. Or sometimes it may look slightly yellow, and this is a mucus discharge. Now, the most commonly it is originated from the cervix, and it comes out from the vagina. Now, what is the cause for this? It is caused by hormonal stimulation of the cervix. There are a lot of glands in the endocervix. If those glands are stimulated, they become hypertrophic and hyperactive, and they produce an abundant amount of mucus, and that mucus will come out as leukorrhea. Now, this leukorrhea is a physiological aspect here. Please remember this. It is a physiological, and it is not preventable because hormones are doing it. Okay, and if that lady thinks it is excessive, and if she wants to take a shower, okay, wants to take a shower just to remove it, that should not be allowed, or she should be told that is not good things to do, because washing that thing or taking shower in that particular area, for example near the vagina or even inside the vagina during pregnancy, is not good thing to do because it may introduce the infection there. And another thing, it is a physiological condition. But when that complaint, okay, is brought to you, you should ask some other question. For example, if there are itching or not. The physiological leukorrheas will never itch, but pathological leukorrhea is having itching. That itching is called pruritus. Okay, you should ask whether there is burning and urination or not. It may be associated with infection there, or foul smelling odor. Okay, these all are features of infection, and infection may be causing leukorrhea. Now, this point we have already discussed when we talk about the history taking and physical examination in a pregnant lady. What are the common infection that occurs during pregnancy? Yes, what are those? In genital, in genitalia. Yes, anybody?
So maybe there is chlamydia infection or Gardnerella vaginalis infection.
Okay.
And some.
Good. Some of the point which he has mentioned, Irfan has mentioned, absolutely correct. Very good. He is also saying some other. So let me write few of the organisms name here. One is Candida.
Trichomoniasis.
Good. One is Candida. Okay. Good. Another is Trichomoniasis. Excellent. Trichomoniasis. Trichomonas vaginalis. Okay. Candida infection. And some other non-specific
bacterial vaginosis.
Exactly, infection. Non-specific infection like bacterial vaginosis, okay, chlamydia, those sort of organisms. Excellent. We are going to talk about everything in the respective topic later on. Now there's a picture which is included here just to explain how this leukorrhea looks like when we examine by speculum. Now see here, this discharge, this white sticky type of discharge is called leukorrhea. Okay, now this pink type of appearance is seen because of increased vascularity of the cervix. This is cervical opening. So this is cervix, there is a cervical opening, and this white substance is the leukorrhea. Now after this, let's talk about what are the discomfort related to the urinary system. Okay, urinary system. Now see here, one of the very common complaint during pregnancy is increased urinary frequency and urgency. Now frequency means more, okay, than normal, more time than normal. This is frequency, everybody know that. But urgency means she cannot hold the urine. Whenever she wants to urinate, she has to go quite quickly. She cannot hold it for a long time. That is called urgency. What may be the cause for that? This is caused by vascular engorgement and altered bladder function. Now, the reason for that, okay, because of the hormone, okay, there is reduction of the bladder capacity, and due to the enlarging uterus and the fetal presenting part, that fetal presenting part may compress the urinary bladder, and the enlarging uterus can also do the same. And this is more common in the first trimester and the third trimester. Now, in the first trimester, the uterus is enlarging. Remember, only after first trimester it will cross the symphysis pubis, and it will go to the abdominal cavity. Before that, it is still in the pelvic cavity, but it is enlarging inside the pelvic cavity, and that enlarging uterus will give pressure to the bladder neck, resulting in urinary frequency and urgency during the first trimester. And in the third trimester, if the baby is having cephalic presentation, which is the most common one, that head may again give pressure to the urinary bladder. During second trimester, I should say, the urinary frequency and urgency is not that commonly seen. Now, what are the intervention, okay, the pregnant lady can do, and what we can advise to her? Just let her know that this is normal. Okay. This is normal phenomena. She should limit the fluid intake before going to bed, especially during night time. Otherwise, the sleep will get disturbed. She should wear perineal pad, because sometimes because of this urgency, the urine, okay, urine cannot be held, and there may be slight trickling of the urine outside, or dribbling of the urine, so that can happen. So perineal pads has to be worn all the time, and notify the physician if pain or burning is noted. These are the features of urinary tract infection. These should not happen in case of urgency and frequency. If pain or burning urination occurs, this is a feature of UTI, and UTI must be treated. Now, another important point in urinary system is stress incontinence. Stress incontinence. So see there, incontinence means unable to, okay, unable to hold urine. The urine is dribbling on its own. Okay, sometimes even without the knowledge. This is called incontinence. And in this case, okay, in this case, if she develops a bit of pressure, okay, a bit of pressure, for example, straining, then also urine will dribble. So this is called stress incontinence. Incontinence is a very important term. That means the urine is, okay, getting out on its own. There is no control now. This occurs later in pregnancy. The patient may actually void on herself, sometimes even without the notice. And this stress incontinence is caused by enlarging uterus and pressure on the presenting part of the urinary bladder. Same explanation again, okay, same explanation. Now, what can we tell her to prevent from this stress incontinence? We need to teach her how to do Kegel exercise. Now, this Kegel exercise is all about alternate tightening and relaxing of the muscles of perineum. So this will tighten the muscles there. So probably this stress incontinence will not happen. Encourage the mother to wear perineal pad. Accidentally, if urine is dribbled outside, then that perineal pad will soak it, okay, and inform the patient to notify the physician so that rupture of the membrane can be ruled out. If it keep on happening, okay, even without any strain or stress, then sometimes premature rupture of membrane has already happened, and she should quickly go to the hospital. Because if PROM, which is called premature rupture of membrane, happened about 18 hours already, and she has not even went to the hospital, then the ascending infection can occur, and baby may be infected, and even the uterine cavity may be infected. So these are the important point. Now, this is the last slide, okay, of this particular topic actually, but this is very important one. So all of you, please focus on your screen. This is all about what are the danger sign during pregnancy. If this danger sign is developed by that lady, then she should report quite early to the obstetrician. Number one is vaginal bleeding. Any vaginal bleeding during pregnancy is always, okay, is always a serious problem. So the possible diagnosis can be, okay, if it occurs in the early pregnancy, that may be a case of spontaneous abortion. If it occurs in the later pregnancy, it may be a case of antepartum hemorrhage, okay, antepartum hemorrhage. Antepartum hemorrhage can be commonly caused by two conditions, abruptio placentae and placenta previa. All these are important topic in obstetrics, okay? So we are going to talk them one after other. Now, vaginal fluid leakage from the pregnancy may be a danger sign, but not always. It may be a danger sign if there is a rupture of the membrane, which is called premature rupture of the membrane. And another is urinary incontinence. Incontinence is taken seriously. Epigastric pain may be a feature of severe preeclampsia. Now, preeclampsia is pregnancy-induced hypertension with proteinuria. We already talked about. In pregnancy-induced hypertension, okay, there is affection of the liver. There is affection of the liver. We call that HELP syndrome. Okay, HELP syndrome. So let me write that for you here. Now, see here, what may be the full form of this? So let me explain this for you. Okay, now see there, H is hemolytic anemia, EL means elevated liver enzyme, and LP means low platelet. Hemolytic anemia, elevated liver enzyme, and low platelet. Now that elevated liver enzyme occurs because of hepatitis or because of the involvement of liver. And if whenever liver is involved, we may have epigastric pain, right hypochondriac pain or epigastric pain. Liver is a big organ. Always remember that. The lower left lobe of the liver is mainly present in the epigastric area. So that's why it is written like that. But that lady may also have right hypochondriac pain. Now, this is also a special topic later on, okay? So you just know the meaning now. All the important points we'll highlight later. Uterine cramping. It may be caused by preterm labor or preterm contraction. And preterm labor is a danger sign because the baby is delivering quite early, so she should run towards the hospital. Decreased fetal movement by the lady, felt by the lady, I should say, is always a danger sign. Always. This may tell the fetus is already dead, okay? Or sometimes there is fetal compromise. The fetus is in trouble, so a quick, okay, admission in the hospital and then investigation and management is necessary. Persistent vomiting during pregnancy is a danger sign. It may be a feature of hyperemesis gravidarum. Hyperemesis gravidarum. Hyperemesis means excessive vomiting. Gravidarum is a pregnant state. It may be a feature of hepatitis during pregnancy. Now, out of the those 5 important hepatitis viruses, one hepatitis virus causes infection very commonly during pregnancy. What is that? Anybody? Which hepatitis virus? Okay, so probably you have not studied that, and that is hepatitis E. Okay, remember this, hepatitis E very commonly causes infection of the liver during pregnancy. Other hepatitis also can occur, but hepatitis E is much more common. Pyelonephritis is the infection of kidney area. It can also lead to persistent vomiting. Headache and visual changes, okay, shows severe preeclampsia, means because of the excessive rise in blood pressure, probably there is increase in intracranial pressure, probably as a result of cerebral edema. Pain with urination, cystitis and pyelonephritis, these are the part of UTI or urinary tract infection. This has to be investigated, confirmed, and then treated. Don't give any antibiotics just like that, okay? You need to make sure whether UTI is there or not. Then only choose the appropriate antibiotic and prescribe to the pregnant lady. And lastly, if chills and fever, okay, chills and fever. Chills, what is chills? Chills means what?
Cold sensation, sir.
Exactly, cold
And
sensation,
shivering.
Feeling of coldness, sir.
okay,
Just like sharing.
exactly. Now see here, there is a, exactly, so there is a slight difference between chills and rigor. Chills means feeling cold, rigor is shivering, okay. Usually these two occur together, chills, rigor. So chills means feeling cold, rigor is shivering. So chills and fever, look at the conditions here, pyelonephritis and chorioamnionitis, both of these are infection. Pyelonephritis is a part of UTI, chorioamnionitis is infection of that membrane, okay, which is present inside the uterine cavity.